That's it recorded. Thanks for the reminder. I had completely forgotten about that. Why is this not sharing? Can you see my screen? I can't see it. No, okay, I didn't think so. What have I done? Share. Just hadn't pressed share. That's what happened. I think because there's so many of us in this session, I think using the hands up feature is probably the best way to discuss things. There's no point in using the chat because whilst I'm presenting, I can't see it. So just use your hands up and then I'll call you up. I also apologise that I am looking at that screen but talking to you. It's because you guys are on this screen, the camera's there, but the X-ray's there. So how we look at X-rays. This is the ideal way to look at an X-ray. In fact, if anything, it's a bit big. But one of the, and there aren't many, but one of the downsides of digital radiography is the capacity to over-manipulate your image, to darken it and lighten it, to zoom in excessively, and the background that you're viewing it on. So the more you zoom in on a digital image, the more likely you are to find things that aren't actually there. It was never designed to be looked at that way. Obviously, I'm looking at this on a massive screen. I'm guessing most of you are looking at it on a laptop. But even on a laptop screen, it's maybe a little bit bigger than would be ideal. I definitely would never look at a single image full screen. The other thing that I've done here is it's on a black background. That's very important. So when you get sent your unseen cases, or when you're looking at X-rays of your patients on your desktops on Clinic, you need to get that image on a dark background, and there's loads of different ways you can do it. I stuck that on a black PowerPoint, but you could put it, even if you just put a black screen behind whatever program it is that you're using to view it or whatever, but do try and look at it on the black background. And the other thing is, ideally, turn the lights off and try and not have very bright sunshine coming through the window as I do here. Makes a huge difference to view them in a dark situation. You see the contrast much better when you don't have a bright light shining at it. So when you're doing when you're looking at the radiographs in your unseen case, sit in a dark room. I appreciate on Clinic that might be difficult in a polyclinic situation. If you're in your own surgery, turn the lights off. I don't mean it has to be pitch black, but just with as less artificial light as possible. And it just makes the lights and darks as they're supposed to be. Okay. Now I'm going to skip past this one because I'll come back to it. Let's see. Let's go for the good one to start with. Okay. So, what are we looking at? What type of... Some of this is going to be really basic and some of it's going to use a bit more thought process. What type of image are we looking at?
Right hand side bite wing.
It's a bite wing, yes, a right bite wing. Great. And what teeth are visible on that image?
A 1/8. 1/8.
What's making you think 1/8?
The root for morphology.
Okay, can't quite see enough of the root morphology in a bite wing to make that decision. And without seeing the chart, you could call it a 1/8, you could call it a 1/7. It wouldn't really matter. With the information that we have right now, I would tend to go with a 7, just because it doesn't look like there's ever been a space and the teeth aren't tilted at all. But it could be. It could be an 8 and a 7, or a 7 and a 6, possibly even an 8 and a 6. There's 2 molars. on the right hand side is probably a good way to put that. What else? What are the other teeth?
The 1-5, the 1-4, the distal of the 1-3,
Mhm.
the 4-4, the 4-5, the 4-6, the 4-7, and the median of the 4-8.
Yeah, it's lovely. So we've identified all the teeth there. Now, restorations. What are you going to say about the restorations on these teeth?
There's a root treatment present on the 1-6,
That's, yeah,
a restoration present on the 1-4.
yep. Anybody else want to add anything?
There's a restoration in 4-7 and 4-6.
Yep.
And is inadequate, actually, is a root canal treatment in 4-5, or is the post, I don't know.
There's a post in the 4-5 for sure.
Yeah.
There may be a root treatment as well, but we can't see it. So there's definitely a post in it. Okay. What do we think about, from a radiographic perspective, what do we think about discussing materials that these teeth are filmed with? I'm sorry if there's background noise, by the way, but it's 800 degrees in this room and I have to have the window open.
You can see a lining present in the 1-7 where it's been root filled, just because of the different shadings of the radiograph on that, and then possibly filled with a composite because it's lighter in comparison to the 1-4 that's been restored. I would say that the 1-4 is possibly an amalgam.
Right. So the contrast that you're seeing on the 1-6 actually it's developmental, and I know that for certain because it was an issue we were having with the X-rays here. So I think it's fair enough to say there's a difference in contrast. But actually, it's not because of what's in the mouth. Can you tell, looking at an X-ray, what material has been used? Just from the X-ray, not knowing anything about the patient's mouth, but in an X-ray report.
No.
No, you can't. We can suspect that the 1-5 has a metal-based restoration in it. I can't tell that looking at the X-ray what material that is. I can say that there may be a difference in radiolucency, perhaps between the restoration on the 1-4 and the restoration on the 3-6. Actually, it doesn't matter. So when we're discussing radiographs, unless you can see in the, well, in fact, full stop. When you are looking at just a radiograph and in our radiograph reports, we don't mention material because we don't know. In your unseen case, unless you have a chart that states the material, you don't know what material that is. So in radiograph reports, when we're discussing radiographs, I want to hear that there's a restoration, but we don't want to hear what material it is because you don't know. Christine?
Sorry, I don't know if anybody else does this in Inverness, but we do report it like that. So when I have been taking radiographs on Radiography Clinic, I have been stating what I think I see because of the contrast, and then putting a note to match it up clinically.
So obviously in that situation, you've got the patient notes, so you can say in the patient notes what that is, but in the radiograph report, it shouldn't mention the material. So just say that there's a restoration, and if there's any secondary caries or anything like that about that restoration, or if there's deficiency, overhang, all that's great. But in the radiograph report, you shouldn't make reference to the material. In the same way as in a radiograph report, we shouldn't say that there is caries present, because you cannot diagnose caries from a radiograph. You diagnose caries clinically. Now, we can look at a radiograph and say that there's a radiolucency and know to ourselves that almost certainly is caries. But you can't say there's caries just from an X-ray, because there's lots of other things potentially it could be, and it's the same with materials. A lot of people do what you're saying, Christine. It's not uncommon, but from a black and white, right and wrong kind of way, we don't mention material. Continuing on in terms of restoration, I would actually suspect that what is on the 1/6 and the 4/5 are both crimes. But again, I can't actually tell, but the reason that I'm thinking that, let me just scroll on this a second, is that there. And then there's, I think what we've probably got, the metal crown, it's got a Nayar core, that's what's going on there, with a porcelain overlay, and that's definitely what's going on in here. We've got metal core, porcelain overlay. But it's not relevant for the radiograph report. The fact that there's a root treatment is, and the fact that there's a post here definitely is, and the Nayar core, which secondaries you might not know, have any idea of what I'm talking about. The Nayar core, don't worry about it. It's something. It's a retentive feature. In root treated. So we have restorations here, 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 here. Any other restorations present?
1-3 distal.
Yeah, well, I think you it may well be very extensive. We can't see the whole thing. Another thing, actually, in terms of talking about surfaces, I can't actually say that that's an MO. So it could be an MOBL. I can't see the buckle or the lingual component of that. So it's a multi-surface restoration for sure. I don't know if that's buckle or lingual as well as just the MO. Like, for example, the 1/6, you could say that's an MOD restoration, or you could say it's a crown. So let's not state things that we don't know. Right, let me scribble out all those restorations then, so that we can think about anything else. So we've stated our anatomy, okay, because we've done teeth present, restorations, root treatments. There's nothing else really there I would state in terms of anatomy. So let's think about pathology. Let's use our hands up. Tell me about an area, or if there are any areas of pathology on this radiograph. Kira?
I would say there's a radiolucency present on the distal of the 4/6.
There certainly is, yes. It is secondary to the restorations presently. I'll take that ring off. What would you put on that in terms of epitaphs?
It looks to me like it's kind of in the inner third of dentine, so I would say an RC5.
Yeah, that would be fine. It's a little bit tricky to see where the pulp is towards the distal of that tooth. Why do you think that might be?
It's maybe shrunk away a bit because of the caries that's present. It's retreated a little bit.
Yeah, the caries and the fact that it's got a restoration in it already that's probably been there quite a long time. So, like, kind of, I would suspect the pulp is like maybe doing that. But either way, it wouldn't really matter whether, in terms of outer or inner third, that hasn't changed. What would change is whether it became a 6 or not. So yeah, I think that's fine. Fair enough comment for that one. Okay, anybody else want to? Is there any other pathology anybody wants to mention? No. I don't think there's any other radiolucencies that I would suspect to be caries, or the way I like to put it is the radiolucencies that warrant an ICDAS score on there. There are a couple of things, however, that I would still mention in pathology. I would say that there are deficiencies in that restoration because there's a gap, or there appears to be radiographically a gap between where the tooth finishes and the restoration commences. That's all I would mention on this radiograph. So I'm glad nobody's seen anything that I don't think is there. Oh, bone. We haven't made comment on bone loss, sorry. What do we say in terms of bone levels?
Could you say there's vertical bone loss on the 1-4 mesial?
I see what you're saying, because the bone, like, the bone's kind of like this, isn't it? And then there. It's hard to say whether that's vertical or horizontal without seeing like 3, 2, 1. So I would take that there as your area of the worst area, albeit not a massive change. I wouldn't necessarily call that vertical with the amount of information we've got. Christine?
I did see a question on the dental hygiene therapy network earlier today, and it was about bone loss, but then there was a theory, I think that somebody had commented that you can't diagnose bone loss without seeing the full size of the teeth, and just wanted your opinion of that.
I commented on that post actually. That I disagree with what the person said. This is a really good example of forget what we were just talking about at the 1-4. Forget that situation. You can see the bone levels on that radiograph, no bother. What we have to be able to do as clinicians is piece together the rest of the jigsaw to estimate. It's always an estimate, the bone loss. So if I was going to carry on, let's say, no, probably a bit longer. Maybe about that. So I'm just guessing there's probably, well, not guessing, I'm making an educated estimate that there's probably the same again extending towards the apex there. And then I can put an estimate on my bone levels. So if we forget about the mesial of the 1-4 just now, what would we say about bone loss on this radiograph?
Normal, less than 10%.
Okay. Less than 10% I agree with. In fact, if we're thinking about it from a BSP perspective, less than 15 is the that's the cut-off between 1 and 2. So if you're going to just say less than 15%, maybe I think there's less than 10% there. Now, normal is a tricky one to say, and that's something that I perhaps would have said until very recently. But normal is 0. And I don't know if I would say that there is 0% bone loss there. I think we have some crystal loss, particularly on the lower. See, like that's very straight there and very straight there. And also you can see the lamina dura on the upper, but not on the lower if I'm above that pen. So I don't think it's true to say there's 0 bone loss. In which case, from a perio perspective, we're talking about stage 1. But there's definitely not a lot. Now, if we factor in this area between the 1-4, now that would be a difficult area to try and put a bone loss on because we can't get a full picture of it. So in this situation, considering the pocket chart as well, I may take a supplementary periapical. To go back to the whether we should be taking periapicals or not throughout the rest of the mouth, what does the guidelines say with regards to what radiographs we use for periodiagnosis?
Periapical is a gold standard.
In what situation? Because we can't take periapicals for everyone.
For diagnosing bone loss.
Okay.
If patient has a BP of 3 and 4,
Okay, that is, yeah, no, you're right, that's one take on it. There's another way to describe it that it depends whether you're looking at FGDP or BSP SDSIP. So if there's a BP of 3 or 4, that would warrant a periapical. Or
Full mouth pocket chart and take PAs in the sextants of pockets smaller than 4 millimeters.
generalised pocket more than 4 millimetres, yeah. Now, I would not expect that mouth there to have pocket more than 4 millimetres. So I can't justify taking a periapical. One bite wing has given me enough, I'll come to you in a second, Kernis. One bite wing has given me enough information to make a perio diagnosis, as opposed to a minimum of 2 periapicals. Every exposure has a risk. We have to use our alert principle as low as practicably possible. Kernis.
Isn't the BPE sort of your guidance for taking PAs and not the actual sort of bone loss from bite wings?
So I suppose the first thing to say is the justification for taking a radiograph is individual and there is some subjectivity in it. So if I, as an individual clinician, am justifying an exposure and we're in a slightly grey area, do I, don't I might make one decision and another clinician might make another decision, and as long as we can personally justify it, then that's okay. To sort of build on what you just said there, if we already have radiographs and they are sufficient, so if we already had those bite wings and they were sufficient, you wouldn't then take more radiographs simply because you wanted a periapical. If you've got the information enough, then that is what you use. And that's why it's very important to always check what radiographs somebody already has before you take any more. Which is very relevant if you're working in a place where you're not seeing the patient's complete record. For example, if a patient's been referred to you from somewhere else, you need to get the information from that original referrer as to what radiographs they've already got. Whether we use the BPE or the pocket chart to decide which radiographs we take, again, depends on which guidance you're looking at, because do we do it based on BPEs and 3s and 4s, or do we do it based on pocketing depths of 4 millimetres or 6 millimetres? Now, if you're doing it based on 4 millimetres or 6 millimetres, that's your difference between your vertical and your horizontal bite wings, and then your periapical, then I need a pocket chart to do that. As a prescriber, I would base my justification on the pocket chart. I would do my pocket chart first and then take the radiographs based on what I've seen on the pocket chart. Because if you think about it, if you're doing it based on BPE, which obviously describes the whole sextant, if you're, let's say you've got a BP of 4 on the upper anteriors, how many radiographs would I be taking to get periapicals of all the upper anteriors?
Three?
Go again.
5.
4.
Yeah, it's 3 on the lowers, 4 on the uppers for the anteriors. Because we've got the 3, the 2 and the 1 and the 2, and then the 3. So that's 4 periapicals. However, there may only be a pocket on one of those teeth, but the BPE would be a 4. So I would rather do my pocket chart, see which teeth are affected, then take my periapical. Yeah. But it isn't wrong to do it based on the BPE, because other guidance says to do it that way. So it can be justified in a various number of ways, and how you as a clinician justify it, as long as it's evidence-based, is the way to go. I just wouldn't take periapicals and done a pocket chart. Also, you need to make sure the person's motivated, they're going to keep coming back, all this kind of stuff. You might as well just wait until you've done. It's more of a why not. Why not do your pocket chart first? I can't see any disadvantage to doing your pocket chart first. Christine?
So would it be right in saying that you'd be taking a full mouth periapicals because if you had BPs of 4 in that anterior sextant, and you'd be following the BSP guidance, whereas your justification, you'd be following the FDGP guidance, is that right?
Yeah.
Okay,
Exactly.
thank you.
Yeah. So, to go back to the original thing about bone loss there, yeah, I would say 10%, less than 10% bone loss, but there is crystal loss. Therefore, this is patient for a perio diagnosis. Not necessarily for a pocket chart, but for a perio diagnosis. Okay. Anything else anybody wants to comment on or ask about that radiograph? No? Okay, cool. Right, let's see what else we've got. Okay. I'm going to let you have a look at that for a minute. I need to get a drink of water and try and find a fan somewhere. Not much yourselves if you want. That's a silly design. Oh no, it was that way. It's a clever design. Okay. What image, what type of X-ray is this? How would you describe the image? Artemis?
Is it right bite wing?
It is another right bite wing, purely by coincidence. And what teeth can we see on that?
Upper right is a 161,514 and 4,54647.
And what else would we want to mention in the anatomy side of things?
For 6D restoration present.
Restoration present, yes, on which tooth?
For 6DO.
Yeah, there's can't technically call it a DO because it might also be included in the lingual or the buccal. There's a restoration present on the 4-6, yeah. Okay, cool. That's your anatomy. What about pathology?
The widening of the PDL.
Sorry, I'll start with Lindsay.
Sorry. Is there widening of the PDL on the 4-6, 4-7?
Yeah, there is a bit, particularly there. maybe a bit there. Yeah, that's fine. I didn't catch who else was speaking at the same time. I'm sorry.
It's like me. I just want to ask you, is it in 2, 4, 5? Is there the theory in the distal?
And the 4, 5.
Yeah.
Okay.
Am I wrong?
No. So caries is not the term we would use. How else would we describe it? Because I can't see caries because that's not a real tooth.
Radiolucency.
Yeah, there's a radiolucency. I think there is a radiolucency in the 4, 5 distal Bahar. Well done. What ICDAS score would you put on it? I think you're muted. Can't hear what you're saying.
Oh, sorry. I just put RA1
Yeah,
because
good.
it's not in the cement to enamel junction to be RA2.
Definitely. It is only in, well, it's really hard to draw such a small line. It is only in the enamel. So yeah, RA1, good spot. Anything else anybody wants to mention? Christine?
Is there radiolucency in the 4-6 distal, slightly under the restoration?
Okay, I'm glad you mentioned it. So this area here, does appear to be darker. However, I would not, without looking in the mouth, record that as radiolucency more in an ICDAS score. What you're seeing there, right, this is hard to explain. It's not actually there. What we're seeing is a dramatic contrast between a very light area and a darker area. Now, it should be darker in this area because we're almost, that restoration is almost at the ADJ. We've only got a tiny slither of enamel underneath it, like that bit. So this area here is at the ADJ. If you look at there, and to some extent there, and definitely there, it's looking similar. So when you've got bright restorations, usually because they're amalgam, but we can't tell that just from looking, you do get contrast. So it's not a radiolucency warranting an ICDAS score. The other thing is there is no difference in the density directly under the restoration to what there is in the tooth about here. But that, it's not in the right shape for it to be caries. That was caries, it would be looking in like that. And it's not, it's travelling laterally down the tooth. Not laterally, vertically down the tooth. So, and following the contours of the tooth, and all that suggests that that's not caries. If you wanted to, you could certainly say there does appear to be a darker area underneath that restoration. It doesn't follow the pattern of caries, however, so I would need to check that clinically. And I would look at it clinically, for sure. But I wouldn't go straight to caries. But I'm glad you mentioned that, because that's a common thing for people to question. Any other thoughts on this radiograph?
1-6
Oh, sorry.
mesial, 1-6 mesial, 1-5 distal, RA1, and the interproximal kind of region bit.
Are you talking about where the teeth meet, or are you talking about down at the bone level?
It's where the teeth meet.
Okay. I think there is the tiniest bit of overlap there, which is making it difficult to see. I wouldn't necessarily say you're wrong, and if you wrote RA1, yeah, like, it's not as if that's going to make a difference in terms of treating it. But I think it's probably just a tiniest bit of overlap.
Lindsay, in the 1/7 in the mesial, is it a radiolucency or is it like a
Which tooth are you referring to?
what? Sorry, 1/6. Oh my God,
No?
sorry, 1/6.
Yeah, I think that's the same thing that Lindsay was just talking about. I think there is some overlap, like tiny little bit of overlap, and it's making it difficult. I wouldn't necessarily say that is a radiolucency, but if you called it an RA1, I'd be okay with that. What QA grade would you put on that radiograph? Lindsay?
Acceptable because it's diagnostically okay.
Yeah, absolutely. It's not perfect. It's obviously a little bit coned at the bottom, and there is a little bit of overlap between the 1/4 and the 1/5, but it's totally doing the job. Cool. Right, let's see if I've got a decent pediatric one. I'll come back to that one. Okay. It's another right bite wing. This is purely coincidental. There's another right bite wing. Right, what teeth are we seeing on this radiograph? Bahar.
I can see 1/6, 5/5/5/4/5/3, and distal of 5/2 in the upper, and the lower I can see 4/6, 8/5, 8/4, and 8/3.
Nice. The only thing I would say there is what you described as the distal of the 5/2. We don't actually know if that's 5/2 or a 2/2. She can't see enough of the tooth. And given that they've got 6s, it's probably a 2/2. So I just wouldn't mention it, to be honest. It's we don't know. Not enough information. But yeah, nice spot. So we've got a combination of permanent teeth and this into this teeth. Okay, there's one very obvious element of pathology. Well, actually no, before we move on, what else could you describe in terms of anatomy on that tooth, on that radiograph?
Root resorption.
Solution.
Let's stick some hands up, please. Flora.
You can also see the sort of crown of the 4/4, a slight crowning of the 4/5. Yes, yeah, 4/5, and possibly you can possibly see the 1/4 crown as well.
Yeah, I think we're probably seeing like the top of the germ. But yes, good. So we've got some permanent teeth unerupted, but showing their head, which is an important thing to note, because obviously we know they're coming. Now, somebody said root resorption, whereabouts? Artemis?
There's a 5/5 in tiny.
I
As a
wouldn't
me-
say.
is
5/5 doesn't look like it's got any root resorption. This root is fully intact.
it a right thing. Okay.
8/4.
Okay, yeah, so down here. Definitely got resorption of that root there. Okay. Anything else anatomy wise you would want to mention? I don't think there's anything other anatomy I would want to mention. Okay, we have a very obvious pathological lesion. Where is that? Artemis?
Is it 8/4 distal?
It is. And what test score would you put on that?
Is it RC5? The reason is because of the white line is still there, is not attached to the root yet.
Is anybody have anything else they want to say?
I put
I'll
RC6.
say RC6. Same.
I would call that a 6. I see what you're saying, Artemis. There is a line there. However, I think what all that is just a little, there's probably a bit of enamel hanging on. But there isn't a distinction between the caries and what would be the pulp space here. It's going all the way down there. So I would call that a 6. And given that it's a D with what appears to be a breakdown of the marginal ridge, it's almost certainly going to be an RC6 anyway. Once you've lost the marginal ridge of the D, it's going to be pulpily involved. So yeah, ICTA 6 on the 8-4. Anything else that anyone wants to mention? Lindsay?
Bone levels are normal.
Yes, because this is obviously a young child. We wouldn't, unless something radical is going on, we definitely bone levels are just normal, so that's good.
Can you say normal for a child? Like,
Yeah.
yes,
because
okay.
with a child, because obviously you've got erupting teeth and exfoliating teeth, unless we were seeing something that could not be explained by an eruption or an exfoliation, it's normal. Okay.
Sorry, I have a question. In tooth 4-3, what's happening there? Is it erupted or is not
It's
erupted?
rotated, I think, probably.
Okay.
I think we're seeing the tooth side on rather than front on. But you wouldn't be able to tell without looking in the mouth. But I think that's probably what it is. Okay, I agree there's no more pathology on that radiograph, and I'm really pleased that everybody thinks that. I would like, however, for someone to attempt to explain to me what that radiolucency there is on the mesial of the 5-4, because I don't think it's caries. Christine?
I'm going to take a shot and say, is it like anything to do with hypomineralization? No.
No, it's a perfect, healthy thing. Upper D's. In fact, yeah, more so upper D's, but they often look like that on a radiograph.
Or is it the positioning? Well, no, I was going to say the positioning of the tooth, but then I'm looking at the roots as well.
Not so much positioning of the tooth as such, but you're sort of on the right lines.
Is it just a burnout?
No, burnout relates to the cervical region. There isn't really a lot of burnout on this radiograph, maybe possibly there. You see burnout underneath the ADJ if you're going to see it. So no, you wouldn't have burnout in that area.
Like a ghost shadow.
Good shout, but no. This all comes down to anatomy. Bahar?
Can we call this one cups of Carabelli in SD7 that we said?
So it's not a cusp of Carabelli because that's on a 1-6, but that is just a cusp.
Oh, yeah.
It's just a thinner part of the tooth. A thin bit of tooth is a lot less dense than a thick bit of tooth. So upper 4s often have a sort of little, it's not an extra cusp, it's just the mesial cusp. But it's just a thin, because this is 2D. So the tooth is fatter in the middle than it is at the mesial and the distal, and an upper D is often really thin at the mesial. So it's just that the more x-rays, it's not absorbed the x-rays as much. Similar to why the 6 is more radio opaque than the E. It's just because it's a thicker tooth. So particularly with deciduous teeth, when you're looking at it approximately, I always want you to think, is that just dark because it's a thinner bit of the tooth? Because I definitely saw in the unseen case exams, in both second and third year, people diagnosing that kind of radiolucency as caries. And it's just the shape of the tooth. The other reason I know that's definitely not caries is, first of all, it's a weird place to get caries. Caries doesn't start at that point. Caries starts underneath the contact. And secondly, it's not the right shape to be caries. Caries would have a break through the enamel somewhere, and there is no break in that enamel. And it would have gone like that, but it's just in totally the wrong place, really. You wouldn't have, just wouldn't be there. And I think we can probably all agree that's a QA acceptable. There's absolutely, well, it's not entirely true to say there's absolutely nothing wrong with it, because there is overlap between the E and the 6. But given that there's no overlap on the upper, I would suspect that's actually just because of the position of the teeth in that person's mouth, although it would be unusual. But there has been drift because the E has drifted into the distal cavity of the D. So the 6 is further muesli than you would expect it to be. But either way, it's an acceptable image. Next. I'll come back. There was one. What time are we on? Okay, let's go with this one. What type of image is this? Artemis?
Is it bright white wing again?
That's not a bite wing.
I don't know.
I know there's upper and lower teeth in it. We'll come back
Yes.
to it. A bite wing. Lindsay?
An upper right PA.
Yes, that would be a PA. Now, obviously, we don't know because we don't have the referral, so we don't actually know what teeth they were aiming for. We can talk about the teeth that are on it. So, why have we ended up with lower teeth showing a little bit on a periapical of the upper arch?
Because the patient's missing teeth below, so they've bitten on like the holder and it's just like shot up.
Dropped into the space. What could, we weren't there, so there was quite possibly a reason, but what possibly could help prevent that?
Using a cotton wool roll in place.
Yeah, probably a few cotton wool rolls to try and fill out that gap. Or, if the patient has a lower denture, make sure they've got it in to take the image. Not an upper denture, obviously, but if they had a lower denture, it'd be useful. So, just because there's lower teeth doesn't mean it's not a periapical. It wouldn't really have made a huge amount of difference anyway, because you've still got the information you need. Okay, so forget about the lower teeth, because this is an upper periapical. What teeth are we looking at?
Looks like 1-8, 1-7, 1-5, 1-4.
Yeah, it's either the 1-8, 1-7. It's a combination of two molars, but I am more inclined to say that's an 8 and possibly a 6 because of the tilt of the most posterior tooth. But doesn't matter. Really doesn't matter. It's two molars. and 2 premolars. Cool. And what else would we mention in anatomy? Alice?
Would you talk about the furcation involvement in 1-6?
So that's pathology. Let's stick with anatomy.
Bone levels.
That's pathology.
Restorations on 1-8, 1-7, and 1-4. If we're just talking about the upper teeth.
Yeah, there's just another those. Okay. So the reason why restorations are anatomy and not pathology is that they're sound restorations. You would expect to see it. As soon as you move on to something that's happened because of a disease process like bone loss, furcations, that type of thing, then that goes into pathology. So for this, teeth present and restorations present are really the only thing that needs to go in anatomy. So let's go, I'll come back to you, Alice. What were you going to say with regards to furcation?
And that was pretty much all I was going to say. That there's
Which two?
furcation present in the 1-6.
Yes. How many roots do these molars have? I'll rephrase that. How many roots do upper molars have?
3.
The finger's got up. 3. Yes. And where are those roots? How are they positioned? Christine?
On the upper right side, it would be 2 buccal and 1 platal.
You say upper right. Would it be different if it's the upper left?
No.
No, exactly, yes. 1 platal, 2 buccal. Okay, just makes a difference when it's left or right. And the 2 buccal, where are they positioned? It depends which way you're holding that hand as to which way that relates, Lindsay. I don't know what you're referring to as which part of the tooth is which.
Is it mesial and distal? Like,
Yes. Yeah. So we've got a platal root, a mesial buccal, and a distal buccal. So furcations on the upper radiographs obviously look quite different to furcations on the lower. Because oftentimes with the upper, you don't actually see that sort of black triangle thing. You just see a less dense part of the tooth. So on this radiograph, we have a root doing that. That's your palatal root. I don't know why I've drawn a bulb on the end, it's not actually there. And then you've got your mesial buccal and your distal buccal. So they're all lying over the top of each other. Oftentimes palatal roots aren't exactly central, but they're more central than the mesial and distal. So there's actually quite a lot of furcation because your bone is right there. Now with this tooth, and this is another reason why I suspect it might be an 8, there are multiple roots and you can see different densities, but it's quite hard to distinguish one root from another. So I don't know if from the radiograph I would say there's a furcation lesion there because I can't tell enough from it. Okay, what else would we say in terms of pathology?
Calculus spurs.
Whereabouts?
There is a distal on A14, mesial 1-5, distal 1-5 as well, and a distal of 1-7.
Are you meaning the first molar that we can see or the second molar that we can see?
The first molar.
Yeah, I agree. Sort of 2 little lumps there. Maybe also there. Yeah, that's probably you. What else? A few things to talk about here.
Widening of the PDL on all those 4 teeth.
Yeah, absolutely. I think they've got a bit of a perio issue.
And the bone levels. So I don't know, would you say the worst affected area was the 1/6 distal at 75%?
Okay, so I'm going to trace the line of the bone. I would probably say the worst is the most posterior tooth, because the only bit you've got left in bone is about there. Whereas on this 6, we've got that left in bone. But I don't think there's a lot in it. Might say that 80% on the most posterior molar. Anything else we want to say with regards to bone loss?
Vertical bone loss on the 1/4 mesial.
Yep.
And I would say 80%,
Yeah.
possibly.
Yeah. Vertical bone loss extended to 80%. When you've got a variety of horizontal bone loss like we have on this, you can put it as a range. You say horizontal bone loss ranging from maybe probably about 50% at this point up to about 80% here. And then a vertical defect extending to 80% as well. So yeah, it's just you use a range if there is in fact a range on the radiograph. Anything else anyone wants to mention or discuss? We have another nice example here of anatomy giving us radiolucency in this area here. It's a thinner part of the tooth. It's the neck of the tooth, and it's where the bone level should be, actually. Well, maybe about there. A 6, an upper 6 is not rectangular in its outline. It's actually a little bit triangular because the palatal root extends obliquely. So if you cut a 6 off at gum level in a healthy perio patient, it would look kinda like that. That's your buccal and that's your palatal. So this part of the tooth is thicker than this part and that part. So all we're seeing here is you can almost see 2 ADJs. You've got a line there. Oh no, I need to be more accurate than that. You've got a line there and a line there. Oh, that's really badly done. I'm hoping you can see what I mean. I'll rub it out so you can see it again. And one of these lines, the one that's heading more towards the centre of the tooth, is this bit of enamel here, and then this bit is the side bit. So it's just overlay. Always got to remember that a radiograph is a 2D representation of a 3D image. And in fact, you can carry this line all the way up to that root, this palatal root that we can see, which tells you it's all connected to that. So Just thinner part of the tree. What is what's this thing here?
The holder.
Yeah, it's the bite block. So technically, that sensor has been placed too far down the bite block. The sensor should, the bottom edge of this radiograph should be there. And then this bit here would have been there, which would have just given you a slightly better image. When you're using, it depends what holders you're using. If you have a sticky bite block, which is what we have here, so the sensor doesn't slide into the holder, it sticks to it. You have to make sure you've stuck it in the right place. And they've just not quite been on the bottom edge of the sticker. The advantage of that, however, over one with a clip is that those don't in any way damage the sensor. If you're using the proper old school ring holders, which you're technically not supposed to use, the actual bite block of the ring, you're not supposed to use with digital sensors because it scratches them in that point where it holds them. QA? What do you think for the QA grade for this?
Acceptable. Sorry, I thought you meant question and answer.
Oh, sorry. QA grade. Quality assurance. Okay. I would say it depends what it was taken for. If that was a PA of the one, let's call it the 1/8, the most posterior tooth, then that's not acceptable because you cannot get a full clear image of the apex. If, however, it was periapical of the 1/6, 1/5, 1/4, yes, lovely, acceptable. So you do have to know what the original request was before you can QA it. But I'd imagine that was taken for the main issue would have been looking at bone levels, in which case it's still acceptable because we can see the bone levels. So to some extent it does depend on the reason for taking it in the first place. Let's do some more pediatrics. That's a bit easy. Okay. I want you to ignore the contrast issues on this. Okay, all this stuff going on here and the fact that this is far too bright. It's just this image has been moved around a lot. It's not in its original format. So just ignore the speckly bits. It's another right bloody bite wing. I don't know how I've ended up with all the right bite wings. What teeth are present on this image, please? Bahar?
It's a bright bite wings is 1655553, and we have in the lower one 478584 and 83. That's it.
Well, yeah, 4/6. I think you said before 7.
4/6.
I know you mean
Yeah,
before
sorry,
6.
4/6.
Yeah, 4/6. Okay, cool. What else would we want to mention in terms of anatomy?
Restoration present on the 8/5.
So,
Yeah, you are correct. That is the right way to put it. I think it's a stainless steel crown, but we don't know that just from looking at the radiograph. So yes, restoration. That's fine by her. I don't think there's anything else to say anatomy wise. You potentially are seeing the very, very tip of a 1-4 there, but not enough to really need to comment on it, I wouldn't say. Right,
You
so
say sorry, root resorption, would that be in anatomy or not?
I wouldn't say there is root resorption. Where are you looking at?
Off like the 5-4?
Because root resorption would be anatomy, because you would expect, unless, well, it depends. If it's anatomy if it's normal for the age of the child. It's pathology if it's not. But I don't think we do have any root resorption there. That root's as you would expect it to be. There's nothing else I would really comment on there in terms of anatomy. What about pathology?
Does 5-5 mesial have an RA2?
Yeah, probably 3. Just think it is definitely into dentine.
And also the 5-4 distal, same.
Yeah, same.
RA3.
Yeah, good.
Is there secondary caries under the 8-5 restoration? Distally.
Yeah, how would you word that in your radiograph report?
RB4?
Yeah, but rather than saying secondary caries, what would you say? Because you don't know it's caries.
Oh, radiolucency.
Yeah, secondary to existing restoration. Yeah, yeah, yeah. It's the positioning of that crown is not ideal. It's sitting quite proud. Now that might be a crown that's literally only just been placed, although that would be a weird time to take a radiograph. I think what actually has happened is the crown has got stuck on that ledge and it hasn't been seated fully. And it looks the same that side as well. To be honest, I would say the crown is too small. But if it's stuck on and the patient's not having any bother, yada yada yada. But there definitely is either secondary caries or a void, but it's a radiolucency and it's getting close to pulp. Anything else anyone wants to say about that radiograph? No, me neither. It's acceptable, obviously. In fact, it's a very nice bite wing of what I suspect is really quite a young child, because there's no sign of resorption on those. Even the D's, probably 6-year-old, maybe, something like that. In fact, you can just about see soft tissue. So those 6s aren't even fully erupted, so that might even be 5. Right, let's do one more for today, because I think we've gone through quite a lot. Right, so you're not allowed to comment on this one, because this is the patient we saw this morning, but it's an interesting one to discuss. And it's not a right wing. What image is this? Oh, sorry, I think I've got a hand up, but I can't see who it is that's put the hand up, I'm sorry. 2 seconds. Oh, I know where it would come in. I mean, it's not telling me who's got the hand up. Oh no, it's not. It's +1 there. Ignore me. Okay, what image is this? Christine,
Left hand bite wing.
not a bite wing.
Upper left PA.
Yes. It's another one that's got upper teeth on it because like, there's no lower molars for them to bite against. So the angle isn't ideal because like, you can see that the bite block is not parallel to the occlusal plane. However, there's no teeth here to bite against, and also we've got a bit of an issue there. So it is a PA of the upper left. Okay, which teeth do we think we're looking at here? Lindsay.
I just said that was like 2.8, 2.6, 2.5, 2.4, and the distal of 2.3.
Yeah, hard to
And then the crown of maybe 3.5
yeah,
or 3.4.
There's 2 molars and there's 2 premolars, and it's hard to know whether that's an 8 or a 7. I think it's charted in the patent as an 8. Doesn't matter though. 2 molars, 2 premolars. Okay. What else do we want to say for anatomy? Lindsay?
Sorry, I don't like to keep answering.
Everybody has the opportunity to, Lindsay. It's just you're the one doing it.
There's restorations present, 2.8, 2.6, 2.5, a root treatment and restoration present, 2.4, and a restoration present, 2.3 distal. Well, you can only partially see that.
The 2, 3, yeah.
Yeah, and restoration present 3.4.
Yes. There's something else I would mention anatomy-wise on this radiograph. Perfectly healthy, should expect to see it. Alice?
Is it the curvature of the root or the root on the 2.5?
Okay, that wasn't what I was thinking of. However, yeah, I mean, it's not pathological. It's weird, but it isn't pathological. So yeah, you would put that in anatomy and say that you've got a good sort of almost 90-degree bend in that root, but it's just how the tooth is. So yeah, that isn't what I was thinking of, but that's a good point.
The sinus
Yes.
here is normal.
Yeah, maxillary sinus. Say the floor of the maxillary sinus is visible. It's so that you're recognising that you know what that anatomy is. Okay, what about pathology? Let's think about pathology from a perio perspective first. I'm not seeing who's got their hand up, but I know someone has.
That's me. I'm just looking at the pathology surrounding the apex of the 2.4.
Okay.
Is that looking at the bone loss, but you can see radiolucency around the apex?
I would describe that in terms of bone loss rather than a periapical lesion.
But in looking at it, would you say it's like, could you say that that's 100%?
Yes, absolutely. That's what it is. Because actually, it's not possible in like physically, but it's almost more than 100% because like there's your apex and there's your bone level. So yeah, you've got 100% bone loss. You've also got 100% bone loss there. So yes, there is 100% bone loss. And that's the tooth, because I think this is a double rooted 5 here. You wouldn't expect to see that, but I think we've got one root there and one root there. Yeah, your bone is actually 100% in parts of that as well, so 100% bone loss is how I would describe that for sure. I wouldn't describe it as a perioendolesion lesion, because it's not endo, it's entirely perio. Because there is no endo for there to be a periapical lesion. There is no endodontic bone. There's only perio. A perioendo lesion, you need to have some bone there as well. Anything else pathology-wise people want to mention? Flora?
It looks like there may be some calculus spurs. I'm just thinking sort of the mesial of the 2-4. It looks like possibly distal of the 2-6, but that also looks like it could possibly be a bit of the root morphology as well. And distal of the 2-8 as well.
Yeah. Yeah, I think you'd be fair enough to suspect that's the calculus spur, but there might be a bit of both. There might be a bit of, yeah, just a funny shape on the tooth, and actually knowing what we know from what we scaled today, although we scaled the other side today, it does seem to have sort of jaggy bits. So yeah, then we got calculus. Anything else? Kira?
I would mention that the lower premolar looks to have a overhang on the restoration that's there on the distal aspect.
Perfect, it certainly does. I know that this periapical wasn't taken to see the lower tooth, but we can see it, so we should comment on it. Nice. Okay. What's going on here? I'll take the pen off so that you can see it in full context, but I just wanted to highlight it. So, what is that? Because it's radiolucency, that part is darker than the rest of the two. Why? And would you put an ICTA score on that?
Is it just catching the root like behind?
Yeah, it's to do with the root morphology, yeah. That's the mesial buccal root. It's an upper tooth. So we've got our 3 roots, and you can just about make out 3 canals. Now, there's more than 3 canals, but from this perspective, we've got one doing, oh wait, one doing that, one doing that, and one doing that. So that tells us that our roots roughly are in that formation. So we've got a root probably about there. Then we've got our palatal root about there. And then I think this root is curving over like that. So that bit there is just all we're seeing is the the distal buccal root. So it's thin. But that would be an area that commonly people might describe as well, it is radiolucency, but not, it's anatomy. The other thing I want to know is, why have we got this line there?
Is the root lying like palatally?
Yeah, the roots are stacked on top of each other. Because it's an 8, probably. The roots are conical, like they're probably fused together a bit, rather than your traditional sort of 3 root formation. And I think you've just got a palatal root and a buccal root lying on top of each other, but they're not the same length. So, this is where the overlap ends, and then that fits only one root then. Oh, okay. We've gone through quite a lot there. Has anyone got any sort of specific radiography type questions they want to ask? No? Anything that we haven't been able to look at today that you'd like me to try and get for next week? Or just more of the same?
More children's ones that I struggle with.
Okay, I've got a few more kids.
Also about the same, more pediatric maybe.
No problems, I can get more kids. There'll be bite wings. I may well struggle to find pediatric PAs because the requirement to take them is so little, but I'll do my best. Do we want to look at OPGs? I've got one nod, so I'll chuck one in. I should be able to find OPGs. Yeah? I definitely don't have any occlusal images because we never take them, so I can't help you with that, I'm afraid. Alright, good. Let's call it at that just now then, and I'll see you for some more radiographic fun next week.
Thanks, Lizzie.
Thank you.
Thank you.
Thank you.
Lazy.